So to start out the day, today we're going to talk about an interesting topic that I was asked to discuss, which is, does adequate antipsoriatic treatment influence cardiometabolic comorbidities? So I'm hoping in today's session that we'll first discuss some of the updates on the relationship between psoriasis and cardiometabolic comorbidities. And then second, to talk about whether any antipsoriatic treatment actually influence these cardiometabolic activities. So oftentimes when we think about the epidemiologic observations that we see, and frequently in my research world, I tend to live on the left side of the slide, I think it is also very important to think how our observations from epidemiology can help inform our understandings with regards to the basic science. And this is one of the meta-analyses that we had done looking at the relationship between psoriasis and hypertension with regards to the odds ratio of hypertension among psoriasis patients compared to patients without psoriasis. I did want to point out, as you can see here, Dr. Cohen's group has contributed significantly really to the epidemiology of cardiovascular comorbidities using the CLELIT database in Israel, and it's actually one of the largest databases that one can use for epidemiologic investigations because of the ability of following patients longitudinally over time and from your nationalized healthcare system. So what we found was that, first of all, in psoriasis patients, the prevalence of hypertension is increased compared to those without psoriasis. What's also important is that in psoriatic arthritis, if you'll notice, the odds ratio is higher than those patients with psoriasis and psoriatic arthritis lumped together. So the odds ratio here is around 2. Our group was interested in understanding if you were a patient with psoriasis and hypertension compared to a patient with hypertension but without psoriasis, would you be more difficult to manage with regards to your hypertension? And what we found was that patients with psoriasis had more difficult to manage hypertension in that they required more therapy than patients without psoriasis. Now let's switch gear a little bit and think about psoriasis and diabetes. We have understood from the literature that in patients with psoriasis, for example, the odds of having diabetes is about 1.6 when we looked at the literature over the last 30 years. And again, this has incorporated a lot of the data from the CLELIT database. And then when we think about psoriasis and incidence of diabetes, so looking at psoriasis patients without diabetes to start with, and then following them longitudinally to look at their development of diabetes, what we saw was that the relative risk is around 1.27 compared to patients without psoriasis. So what are some of the theories that have been put forward to explain these relationships, especially between that of diabetes and psoriasis? One of the key players here is actually adipocytes. It is thought that in psoriasis patients, there is a dysfunction in their adipocytes. And what we see is that in patients with psoriasis, their adipocytes oftentimes can secrete a number of cytokines called adipokines, and they have different effects on the different organ systems. For example, these adipokines affect functions of the liver such that your liver can develop a state of insulin resistance. Second, these adipokines can affect your muscle insulin metabolism and also where your muscle typically wants to uptake glucose efficiently. However, in psoriasis patients, that they found that there is a state of insulin resistance in their muscles. And then it also has direct effects on the pancreas in one of two ways. Number one is that these adipokines can lead to direct apoptosis of our beta islet cells, and those are the cells that secrete insulin. And then for the surviving cells, what it does is that it can make them actually less efficient by decreasing the ATP level eventually in those cells. So what you have is essentially glucose production that's abnormally increased from the liver dysregulations, and then you have glucose uptake that's less efficient from your muscles. And finally, you also have decreased insulin secretion from your pancreas. So all these combined together lead to a state of glucose intolerance and the development of diabetes. When we consider psoriasis and obesity, you probably notice that in a lot of your psoriasis patients, they tend to be on the more obese side. And then when we look at the literature as a whole, what we found was that overall, there's about 1.66 odds of having obesity among our psoriasis patients compared to patients without psoriasis. And oftentimes when we think about the process of adipocyte changes in our obese patients in terms of a few different parameters. One is that we're familiar with the process of hypertrophy, but also you actually do get some hyperplasia of your adipocytes as well. Importantly, during this process, what we also have is essentially we get increased CD8 T cells in our adipocytes, and they can actually form these crown-like structures, which contains increased CD8 cells as well as your M1 macrophages surrounding dead adipocytes. So as our patients become more obese, what happens typically is that they not only have adipocyte hyperplasia and hypertrophy, but they can also have adipose hypoxia, which leads to pro-inflammatory cytokine secretion and downstream events. So this is one of the earliest papers that looked at the relationship between obesity and TNF-alpha. What they found was that in this particular paper of littermates, that obese mouse had about 5 to 10-fold increased TNF-alpha mRNA expression in their adipose tissue compared to their thin littermates. And in this study, they looked at premenopausal women, and what they found is, for example, compared to controls, overweight premenopausal women had greater levels of TNF in their bloodstream compared to the controls. And if they had undergone weight loss treatment, their TNF level decreases. So the key here is that it's not just fat, but rather adipose tissue is an active endocrine organ. Here's a long list of adipokines that can be secreted from the adipocytes. The important part that we see is actually on the right-hand column here. So what we see here is that it can have effect on insulin resistance, as I spoke about, on lipid metabolism, on blood pressure, as well as on our inflammatory pathways. Over here is a list of adipokines that are actively being investigated in psoriasis, and they include leptin, adiponectin, which is actually an anti-inflammatory adipokine, TNF-alpha, resistin, which is related to insulin resistance that I spoke about earlier, IL-6, and also MCP-1. So when we think about cholesterol levels or dyslipidemia in patients with psoriasis, there have been some studies that have shown that there is a difference between patients with psoriasis and without psoriasis with regards to their total cholesterol levels as well as their LDL levels. And it's something that thought to be it is quantifiable among these patient populations. However, studies have been inconsistent with regards to these differences. We had published this meta-analysis in BJD, we had published this systematic review in BJD. We did not do a meta-analysis because when we looked at the literature with regards to dyslipidemia, the outcomes were actually defined quite heterogeneously among the different studies. And therefore, we did not think doing a meta-analysis would do this body of literature justice. But rather, as you can see from this particular forest plot, that there's much more heterogeneity in terms of the degree and the level of dyslipidemia among psoriasis patients compared to patients without psoriasis. Now let's pause for 1 second and focus on HDL particularly. As we know that HDL particles promote reverse cholesterol transport. So it actually removes this excess cholesterol from macrophages and from tissue cholesterol, deliver them to the liver. And this process can limit cytotoxicity of cholesterol. And in fact, this HDL efflux function has been associated with decreased carotid intima media thickness and decreased risk of coronary artery disease. And they also found that in humans who got endotoxin and therefore have a level of inflammation in their body, they have altered HDL size as well as decreased reverse cholesterol transport capacity. So what this tells us is that in chronic inflammation, actually, HDL may lose its anti-atherogenic functions. And it is not only the size of HDL that matters, but also the function. When we take a look at HDL efflux, and this was published in the Journal of Lipid Research here, what they found is that this is a pilot study looking at HDL efflux capacity. So the higher the capacity means the greater retention of HDL's normal ability to transport cholesterol. And what we see here is that among the control patients, they tended to have higher HDL efflux capacity compared to psoriasis patients. And when they looked at the psoriasis patients and they plotted the PASI against the HDL efflux, what they saw was that, for example, patients with higher PASI scores were less able, had lower HDL cholesterol efflux capacity compared to patients with lower PASIs, and those patients had retained their cholesterol efflux ability. And did treatment make a difference in these patients? What we saw was that in this small pilot study, they didn't actually see a change in the HDL level, but they did see that treatment resulted in an improvement with regards to the efflux capacity. And what were these patients treated with? Well, they were treated with a combination of topical agents, phototherapy, retinoids, and biologics. So they had received essentially various different treatments in this particular patient population. And it was a small patient population of 15 patients. So as you can see, from baseline to after therapy here, they had shown a slight improvement in their HDL efflux capacity. And then just as a reminder that when we think about psoriasis and metabolic syndrome, and metabolic syndrome is really a collection of some of the risk factors that I spoke about, the pooled odds ratio is actually most striking, is around 2.26 of patients with psoriasis, their odds of having metabolic syndrome compared to those without psoriasis. And there's a strong dose-response relationship here, which really helped to support this particular observation. So the screening criteria, and I'm curious to see how many of you currently do this in your clinic. For psoriasis patients, that's being recommended is that blood pressure at each office visit in patients greater than 21 years of age, fasting glucose every 3 years in patients that are 45 years or older, and more frequently if the diabetes risk factors are present, and then fasting lipids every 5 years in patients greater than 20 years old. So how many of you either look to see if the patients have had these screening recommendations implemented or implement them yourselves? Okay, great. So I think it is challenging to try to think about the different comorbidities that one has to potentially manage or co-manage with the colleagues in the busy clinic. But I'm encouraged to see that many of you already do so. And then when we look at severe psoriasis and cardiovascular mortality, we can actually quantify that in that patients with psoriasis have 1.4 times the relative risk of developing cardiovascular mortality compared to patients without psoriasis. Now, having learned the updates with regards to the psoriasis and cardiometabolic parameters, let's take a look at the literature with regards to whether anti-psoriatic treatments actually influence these metabolic comorbidities. Before we look at the literature, I just want to show this cartoon from The Economist that was published 2 years ago. So this is important because I think it's very tempting when we see associations to think that there is a correlation means necessarily causation. But this cartoon is to illustrate oftentimes the devil is in the details, how the modeling was done, and whether the confounding factors are adequately controlled. So as we look at a lot of this epidemiologic data, I would encourage us to refrain from making causation statements unless we have very, very good evidence for it. And I'll review some of the criteria for causation later. So let's first take a look at phototherapy and cardiometabolic comorbidities. So it is thought that UV radiation could induce cellular apoptosis, potentially induce immunosuppression, and inhibit cellular proliferation. With regards to narrowband UVB, what has been found is that when you get to around 30 treatments in this study with 50 adults with psoriasis, you could start to see a significant decrease in your CRP levels as well as your IL-6 levels, which I thought was pretty remarkable. And when they looked at PUVA in a different study, they look at bath PUVA. What they found was that in this small study, that there was an associated decrease in the resistant levels, and this was resistant again is related to the insulin resistance that I was talking about earlier. So perhaps bath PUVA and narrowband UVB could potentially alter your your ability of diabetic metabolism. But as you can see, the evidence here is very little, and obviously more study is necessary. What we see with regards to the sunlight and climate therapy is that there's no improvement in your LDL, total cholesterol, triglyceride, or CRP levels, but they did see some changes in the HDL level. How about methotrexate? How many of you think methotrexate alter your cardiovascular risk factors and outcome? So there's good literature in rheumatology looking at methotrexate and cardiovascular outcome, especially in the RA patients. And there's a large study that's going on right now actually looking at particularly methotrexate and its results on cardiovascular events. That's headed by a cardiologist at Brigham and Women's Hospital. That's an NIH-funded study. What about psoriasis patients? So as you can see, when they looked at a population of U.S. veterans with psoriasis and RA, and when we just focus on the psoriasis, what they saw was that there was a reduction with regards to cerebral vascular disease. And the effect was most pronounced in those on low-dose methotrexate and concomitant folic acid, so methotrexate levels of 10 milligrams or below, compared to those psoriasis patients that are not on methotrexate. And this result is essentially also seen in the Taiwanese population when they looked at their cohort of PSC, psoriasis cutaneous disease only patients. However, they didn't really see a significant effect of methotrexate on these cardiovascular outcome in their psoriatic arthritis patients. Now, oral retinoids in cardiometabolic comorbidities. We know that systemic retinoids are oftentimes thought to be associated with increased serum triglyceride and cholesterol levels. So there was a 5-year study that's prospective that's done by Dr. Stern's group at Beth Israel Deaconess Hospital that showed that actually etretinate therapy did not increase the risk of cardiovascular disease in about 1,000 patients with severe psoriasis. And early data shows that acitretin could significantly actually decrease their resistant levels at 1 and 3 months. So I think we definitely, I would say clinically, we see these associated increases in serum triglyceride and cholesterol levels. But whether that translates to, in terms of retinoid therapy in our psoriasis patients to increase risk of cardiovascular disease, it's being challenged by these larger prospective studies. Now, I know that most of the world does not use fumaric acid esters except for Germany, but I did want to show you the literature on this particular work as well. So how does fumaric acid esters work? It is thought to work by inhibit expression of adhesion molecules, and it is also thought to actually suppress TNF alpha and interferon gamma. So in Germany, they had studied this small cohort of patients on 24 weeks of fumaric acid ester, and they actually found some improvement in acetylcholine-induced form blood flow, which was used to assess essentially the vascular compliance, as well as decreases in the CRP levels, VEGF, and resistant levels. How about biologics and cardiovascular comorbidities? Well, there are a few studies that we are going to talk about. First, I'm going to talk about the relationship between TNF inhibitors and inflammatory biomarkers. This is one of the largest studies that have looked at this particular relationship. And in this study, they looked at psoriasis patients that were randomized into placebo, etanercept 25 milligram every week, 25 milligrams twice weekly, or 50 milligrams twice weekly. What they found is that essentially in all of the etanercept groups, they have shown a decrease in CRP levels at 12 weeks. And the effect is the greatest in the overweight and obese patients, statin users, and all patients with psoriatic arthritis. So let's take a look at this particular study results, and we'll focus first on the left-hand side here. So on the y-axis, we have CRP level, and it's in this case, it's expressed as milligram per deciliter. And what we see here, for example, the different shading correlates to the different risks for cardiovascular disease. So the white shading means that there's a low risk for cardiovascular disease, and as we go up, the darker shading means that there's higher risk for cardiovascular disease. And all these lines here, they represent different groups. And as you can see here, in this group, these are the obese patients who are on either placebo or etanercept. So as you can see, overall, when you weight stratify your sample size here, that there's already a difference with regards to their CRP levels. And the trend that you see in all of these within 24 weeks is that there's a decrease with regards to their CRP levels, especially in the etanercept treated group compared to the placebo. So 12 weeks is where the placebo had crossed over to the etanercept group, and this observation is replicated in the other weight groups as well as that in psoriatic arthritis. Now, with regards to TNF inhibitors and vascular inflammation, most of the study have looked at adalimumab and its effect on vascular inflammation. And there are several ongoing studies currently looking at this particular relationship and comparing that to phototherapy. What they saw, so this is one of the earliest studies that was published by Professor Bissonnette's group, which showed that in patients with psoriasis that were administered with adalimumab, you could see noticeable changes in terms of their vascular inflammation internally by PET-CT scan. Again, there's several large studies that are ongoing, and it would be exciting to see if the results bore out by these large studies. And here's Professor Gisondi's study looking at TNF inhibitors and metabolic parameters and inflammatory biomarkers, where he looked at 40 psoriasis patients that were matched to 40 control patients, and they had received infliximab for 12 months. As you can see here, there is a decrease in not only some of the adipokines, as we talked about earlier, but also a decrease in CRP level, but no changes in BMI was noted. And here is another collection of different studies that have shown that actually when we take a look at the TNF inhibitor group, they do seem to influence these metabolic parameters on even pretty smaller scale as well. So it's something that we definitely take note of. One of the larger studies that was published in JAMA in 2011 was looking at the use of DMARDs with regards to the development of diabetes. And they looked at both RA patients and psoriasis patients. But in this particular study, 90% of the patients were RA patients and 10% were psoriasis patients. And so they took patients at baseline who did not have diabetes, and they looked at their treatment regimen and to see which one of them developed diabetes later on. So the model that was adjusted Cox proportional hazards model for diabetes shown that compared to other non-biologic DMARDs, actually, what they saw was that methotrexate here did not make a difference with regards to the development of diabetes. What did seem to make a difference was hydroxychloroquine and TNF inhibitors. So I want to circle back at the question, do certain types of psoriasis systemic treatment cause a reduction in major adverse cardiovascular outcomes? And really a reminder about criteria about causation. And those include time sequence, biologic credibility, dose response, strength of association, strength of study design, and consistency of the studies. So as we know, there was a study that's published by the Kaiser Permanente group that looked at essentially the role of TNF inhibitors and methotrexate, comparing them to topical agents. What they found was that a remarkable reduction with regards to incident MI that's actually greater than any statin drug can produce. I did want to point out that while not in the abstract, in the paper itself, what they found was that longer duration of TNF inhibitors, however, was not associated with lower MI risk. And I quote their own original language was associated with a non-significant higher MI risk compared to the shorter duration. And then again, in the follow-up study, using year 1 as reference, they again noticed that those who received TNF inhibitor therapy for a longer period of time, obviously adjusting for age and a number of other factors, had this non-significant increase in MI risk. And all biologics in terms of TNF inhibitors did not behave similarly. So the benefit that they had been showing was actually mostly attributed to etanercept. And monoclonal antibodies was not associated with a significant reduction in MI risk. I want to bring that paper, highlight that paper, and compare this with this classic paper by Dr. Gelfand's group, where he had shown the message for this paper is essentially patients with mild psoriasis had lower cardiovascular risk outcome with regards to MI incidence compared to patients with severe psoriasis. However, in this paper, the definition of mild and severe were defined by medication usage. So essentially, there were no significant differences in study design, really, between the Kaiser study and this UK study. And even though the comparison group, reference group here, are patients without psoriasis, but even looking at these hazard ratios, one can tell that if they did mild psoriasis as the reference group, that the severe psoriasis patients here, who are mostly patients on methotrexate and some phototherapy and not really any biologic at the time, actually had a higher, as you can see, higher incidence of MI. So the comparison of these two studies is really to highlight that there's a discordance in the literature here. And then in this particular study, what we are looking at is comparing systemic therapy versus phototherapy. So this, on the x-axis is the age, y-axis is a hazard ratio, and this is a 95% confidence interval. So essentially, you can see across the different age groups that there was essentially no difference when you compare systemic treatment versus phototherapy, and you can tell that there's an interaction with the age by this graph. And so what they found, again, there was a trend towards actually increased MI in the systemic treatment group and not a significant difference in the overall MI risk. And I want to point out that the models were run by individual treatment categories as well. So they did not just lump cyclosporin versus the other systemic treatments, but they ran it together as well as individually with each treatment group, and the interaction term that they had noted with the age. And there's further discordance in the literature in that when we look at this Denmark study, when you take into account death, myocardial infarction, and stroke, what they found was that the biologic agents was protective, and methotrexate was agnostic compared to the other therapies. But when you sort of take into account cardiovascular death, myocardial infarction, and stroke, what they found was that in the same cohort, biologic agents were not. So I'm using this as really examples to show that the devil is really in the details of how the models are run, and it is important to note these differences. So I was asked to write a commentary on this for JAMA, and at the time, my comment, and still is today, is that to date, data from population studies are not sufficient to determine with certainty whether TNF inhibitors reduce adverse cardiovascular outcomes, such as MI, in psoriasis patients. And really, future studies need to incorporate direct assessment of psoriasis severity, adjust adequately for the baseline comorbidities. We really need to take a look at the relationship between treatment dose, duration, and these risk factors and events, and also carefully evaluate the interaction terms in the analysis models. So in summary, I think there's continued excitement with regards to epidemiology and its relationship for some of the very exciting translational work in this area. We saw that treatments do seem to influence the metabolic, these surrogate intermediate parameters, but whether they modify ultimate cardiovascular outcome is yet to be determined. Regardless, I think we have a role with regards to manage and co-manage our patients in terms of their established cardiovascular risk factors and comorbidities with our colleagues. So thank you very much.